Why anterior only surgery? Because it provides direct access to release pressure, reconstruct the anterior column, avoid muscle cutting. Why posterior surgery? Because it's effective regarding direct reduction maneuvers in fracture patterns otherwise difficult to reduce, and it's best way to restore posterior tension band alignment. Here is some example I'd like to share with screw pull out downwards and this screw pull out upwards. And here is the PGK with pull out screws in the lateral mass posteriorly. So how to solve these problems is by asking ourselves why 360 operation. 360 approach is indicated for a selected group of patients requiring the advantage of both the anterior and posterior surgery. When to perform 360 fixation is an important question in this presentation. In type C injury, where there is a complete rupture of both anterior and posterior longitudinal ligaments, the disc is torn with an apparent disc herniation behind the body. The posterior column have a fracture dislocation and pedicle fracture, and the posterior tension band is also completely torn on MRI, and that's why MRI is very crucial in severe trauma. As regards cervical thoracic junction, it has specific biomechanical behavior because of the sudden change from the extremely flexible cervical spine to the more rigid thoracic spine. However, in the thoracic spine, it has shorter elastic zone due to the rigid leaf cage, coronal orientation of the facet joints, and the overlapping of the spinous processes over each others. In order to summarize, 26 cases were operated over the past 2.5 years in our spine unit in the Alexandria University, 17 cases with cervical dislocation, and 9 patients with dorsal dislocations, mostly are males, and the age group from 7 to 55 years. Here in case 1, 24 years, a 40 male patient with RTA with C7 right motor deficit. And here you see the complete log deficit and complete dislocation of C6-7. And here is the MRI, which fulfills the criteria that I have just mentioned about type C injury, where the anterior disc is torn and posterior ligamentous complex is also torn with cord signal. And that's what I've done is posterior unlocking with lateral mass fixation and anterior fixation. Another similar case, 31 years male patient with RTA is intact in this patient. Here I use also lateral mass fixation with unlocking and the use of a standalone cage with built-in screws. I prefer using this cage nowadays because it provides an easy go for the screws without any difficulties in as regards the plate insertion. And this post-operative view 2 months later on. This patient is 18 years male patient, RTA is quadriplegic. We see how severe is this trauma with complete translocation and dislocation of C5 over C6. This patient fortunately improved later on. He's not in full motor power, but he's now maintaining his posture and doing well. This is what we have done is posterior unlocking of the facet with lateral mass fixation below, and we have doing corpectomy for the dislocated vertebra with anterior fixation. And we see how good is alignment comparable to the previous one. On the left side with C3, C4 dislocation, and you see how C3 is completely anterior translated over C4. What we have done is the same, but here in this patient, we have go up to C2 and down to C6, and we have done corpectomy for C4 and anterior fixation as well. Patient number 6 is dorsal patient with dorsal trauma, is paraplegic with T8 and T9 dislocation, and we see the criteria that we have just mentioned, anterior and posterior subluxations. What we have done is 3 level above and 3 level below with interbody fusion is very important in this patient because the disc is disrupted. And his post-operative 3 months follow-up with a good fusion at the affected level. The last patient I have to present is a very difficult case with 7 years male child falling from the 7th floor. Unfortunately, he is definitely paraplegic with complete cord syndrome and T89 dislocation. For some reason, he will have a long stay in the ICU before operation for about 2 or 3 months, and he developed a pressure sore over the fracture site with complete kyphosis of about 80 degrees. That's what we have done after stabilization of the patient. Pre-correction, we have inserted our screws. You see how strong is the kyphotic angle of about 80 degrees. And this post-correction, and definitely we have done corpectomy with an insertion of a titanium cage to reconstruct the anterior column. This is the incision after 2 weeks. And this 1 month after correction with good dorsal alignment and good kyphotic balance alignment. And these 4 months after rehabilitation, these 6 months after rehabilitation, and see how he is maintaining his posture. And fortunately, I didn't expect that he will move again. This 1 year after correction. Okay, he is moving his lower limbs. Definitely is not in full motor power, but this patient has learned me not to lose hope in this age group, even if they are paraplegic.
Going to conclusion.
Okay. My take-home message is 3/6 fixation is needed in recent dislocations. Must be done in more than 2 levels anterior corpectomies to avoid anterior screw pull-out. Reconstruction must be in mind in disruption of the anterior column for posterior construct stress relief. MRI is very crucial in all patients with severe spinal trauma to avoid missing posterior ligamentous disruption, which is an absolute indication for fixation. Thank you very much.
Thank you for your nice presentation. Can we call the next presenter, Dr. Amir Al-Ott? Extraspinal findings seen in conventional spine MRI.